Hello Protrusive, I'm Jazz Galati and welcome back to the big one. This is going to be the big one because we've built you up from part 1 to part 2 and now this is part 3. So if you remember, in part 1 we talked about the mindset of that full mouth clinician, how to treatment plan and communicate to your patient. In part 2 we looked at how to get a wax up and how that wax up might be different for an adhesive rehab compared to a conventional rehab, and then how to actually put that temporary in the patient's mouth and let them walk away with the temporaries in their mouth. And I'm very confident that already, just with part 1 and part 2, you probably gained more value from some paid courses, okay? And something that me and Devang are very proud of. But in this part 3, we really get into all the nitty-gritty details, particularly sequencing. So now you have your patient temporaries, they've approved it, they want this treatment, you want to do this treatment, and the patient's suitable and everything's ready to go. But how do you actually sequence it? Do you do the upper arch first, the lower arch first? When do you do the posteriors? How do you do the posteriors? So all those things will be covered in this episode. I truly believe that when a dentist moves away from single tooth dentistry, at some point along that journey, sequencing is discussed. And I think when a dentist starts to think about sequencing, that is a sign. Like, it's like in Karate Kid, you know, wax on, wax off. Like, and suddenly Mr. Miyagi thinks that, okay, now this kid has got it, right? I do believe in our journeys, when you start thinking about sequencing, it's kind of like that, you know, wax on, wax off moment. Okay, now you get it. Okay, maybe you don't get it, but you're thinking in the right direction. So welcome to the world of sequencing for those who haven't considered sequencing before. This is a big step in your journey. It's a step that I'm learning more and more about, and it's great to have guests on like Devang to sort of share his nuggets and his principles. And of course, different dentists around the world will do it differently when it comes to sequencing. And before, that used to piss me off, but now I appreciate the beauty, because you might find a patient that is more amenable to Devang's way of doing it, and then you might find a patient who's more amenable to another dentist's way of thinking. And so if you learn all of these and appreciate the pros and cons, then you can apply it to your patients. To celebrate the fact that Splint course has relaunched. This is my flagship course. I'm so proud of it. We've had over 400 delegates from 16 countries, and it's almost a year old. So now it's been tried and tested by hundreds of dentists, and they love Splint course, and I'm so proud of it. And so now we're opening the doors again to allow a new intake of delegates. This time, instead of opening the doors for 2 weeks, I'm just opening it for 1 week. I just want a select few bunch who are going to be committed for 12 months of support on Zoom, online, and also on the group. And I want you to learn and start implementing how to diagnose and manage bruxism and the correct appliance for the correct patient, when to refer, and how to manage all the nuances of splint therapy. So if that's something you're interested in, head on over to splintcourse.com to enroll and join a community of dentists who want to do better for their patients who are in pain, or you just want to protect the patients from the harmful forces of bruxism, especially if you do full mouth dentistry. So even Devang at the end of this episode, he discusses that, okay, part of the protocol of doing full mouth dentistry is that you give an appliance, because the same things that the patient did to destroy their own natural, God-given, evolution-given dentition, they will do to their brand new restorations. It just seems too risky to give these patients their restorations and rely on the ideal occlusion to protect that patient. It just doesn't make sense. The forces of bruxism are severe. The pearl I'm sharing with you, you kind of need to access the protrusive dental community to see this video, basically. It's a video pearl, and it was a live video my nurse was recording of me, because I had this patient in who I've been seeing for almost 2 years now, one of the most severe bruxis ever, to the extent that he's now awaiting to have a full implant reconstruction, upper arch and lower arch. So quite a big job by one of my colleagues. But he has destroyed everything, and he's been a tricky patient to manage, because he just comes in with these emergencies, and to stabilize him, we kind of need to go straight to those full arch implants, so there's no middle ground here. But for the first time, he came in with a toothache, which wasn't a toothache. And eventually, you'll see the process on how we did it. It was kind of like a diagnosis of occlusion. You do your usual, listen to history, anything hot and cold. No, hot and cold doesn't give any pain. You do a radiograph, it looks fine, there's no apical pathology, no teeth are tender to tapping, right? And then you figure out from the history that the pain doesn't happen when the patient's chewing, it happens just after the patient has finished a meal, and it intensifies. And when you get the patient to point to their source of pain with one finger, they don't point to one tooth, they point all over. So he was pointing to his head, down to his neck, to his ear, right? And these are the clues that the diagnosis was not a simple toothache, it was non-odontogenic, it was myofascial pain with referral. And then there's certain criteria we use, research diagnostic diagnostic criteria in TMD, when we're diagnosing myofascial pain referral, you have to sort of, when you palpate the muscles and the trigger points, it elicits a pain. And then you have to ask the patient, okay, is this pain a familiar pain? And if they say yes, then you say, okay, familiar to what? And then the main thing is that they say, oh, it's the pain for which I am seeking care for. It's the pain for which I am seeking care for. That is the gold standard way to diagnose someone who's having the pain from muscles referring to the head and neck structures. So there's a video of me palpating the muscles, coming up with this diagnosis, just giving you a little bit of like an insight into how we diagnose these things on the clinic. So if you want to check that out, go to Protrusive Dental Community. I'll tag the video for the next couple of weeks as an announcement so you can see that. And I hope you find value from that. So you may be able to think the next time you have a toothache, which doesn't sound like a toothache, you can actually take a step back and consider that could be myofascial pain. Right guys, no more rambling. Let's join Devang Patel on part 3 of Adhesive Full Mouth Rehabs. Dev, welcome back to part 3 of Adhesive Full Mouth Rehabs. It's been a real journey in the previous 2 episodes, and this is really the nitty gritty, the sexy occlusion stuff coming up now. You know, we've done the mock-up and whatnot, we've done the mindset stuff, and now we're going to talk about the how to get that wax up into the mouth, the different techniques, the how do we control the occlusion, the left and the right, and so we're coming on to that. And I'm just going to do a quick recap. Appointment 0 was a mindset for full mouth dentistry. Appointment 1 was the comprehensive evaluation. It was like a checkup, and you sort of screen the patient who's suitable. Then appointment 1A, you bring the patient back and you do a full mouth assessment, some treatment planning, decide, are you going to conform, are you going to reorganize? In most of these cases, you're reorganizing. Appointment 2 was record taking. We talked about FACEBO, CR records. Then we talked about your mock-up technique and how you've guided the technician, and you're doing 4-4. You've sent them home with the 4-4 mock-up, and then when they've come back, you reviewed the mock-up. You're checking how it looks. You're checking the occlusion. So now we're on to appointment 5, which is you're building up the upper and lower 3-3. That's where we're at the moment. So take it away.
Okay, so now I just want to divide next steps into 2, and we're going to discuss about the adhesive composite build-up, but you need to understand the indirect steps for the indirect treatment as well. So the steps for if you're doing a composite build-up, direct or indirect, using some sort of a stent or something, will be for me at least, will be building upper and lower 3-3 and stabilizing the posteriors, and then building the posteriors either one side at a time or one arch at a time. We'll go into detail in a minute. So it's pretty simple for adhesive. And
you're going to explain about what you mean by stabilizing the posteriors, right?
Yes, I will. Yes. So it's pretty simple or straightforward. Whereas if we're doing indirect, let's say we're doing all the crowns for upper and lower jaw, complete indirect full mouth reconstruction, traditional type, then it becomes much more complex. So by this time, if I'm doing indirect restorations, patient would have full mouth provisionals. Okay, and we discussed about we were actually chatting the provisional. The way I make provisional is I don't ask technician to do anything. I would have a wax up of the area where I'm going to do the provisional. So let's say I'm doing 4-4 provisionals, then I would prep the teeth, use the wax up to make chair side provisional. But what I would have done is, after prepping, I would have taken impressions, just without retraction code or anything, just nice impressions, so that technician can make me a lap side temporaries as well. So on the day patient goes with my chair side temporaries, a couple of days or a week later, the lap temporaries comes back and I'll fit that in. Because I find having a shell temporaries, shell maids, it's just too much faff. I've used them, and at least it doesn't work in my hand that quickly. So I don't bother with that. I would just make a provisional chair side, fit them in, and then...
My experience of shells has also been quite traumatic, but yes.
Some people get it really right.
Or chair side ones to lab ones.
Yeah, so I think that works really well, because technician then has a real prep teeth to work on, so it can give me a good marginal fit and everything. So I would do that. So patient will, by the time we are thinking about finalizing everything, patient would have had a full mouth provisionals, and that could take number of appointments. I don't do all provisional in one appointment. Usually I would do 4 teeth at a time, maybe. So it'll take me a lot of time to do that. Once the provisional is done, I would then do the anterior 3 to 3 final. Rest of the whole mouth will be provisional. Anterior 3 to 3 in final crowns. Okay. Then
again, I just want to clarify, we are talking here about the indirect.
Indirect way. This is indirect. So the direct is pretty easy.
So remember, guys, we're talking about the indirect protocol.
Yeah, this is indirect. So the direct protocol is very easy. We're talking about indirect protocol, where everything's temporary crowns in indirect protocol, because you're going to do crowns or onlays or some sort. So you've got temporaries everywhere. Then you're going to do lower anterior 3 to 3, finalize them using porcelain crowns or crowns basically, or veneers. At this point, you still have full flexibility, because if you want to adjust anything, you can still have all the provisionals in the mouth. You can adjust. I'm not adjusting at this point my finals. So let's say my final comes and the bite is slight off. I can adjust the upper provisionals to get the occlusion right. Okay. So you still have ability at this stage to increase the OVD if you want. Okay. But hopefully you would have figured it out in a provisional stage. Once that's done, my preference would be to then do the posteriors, lower posteriors. So lower, right and left, both you can do together if you want, or you can do one side at a time, doesn't matter, to get this occlusal plane flat. Okay, so I would do lower posterior final, then I would move on to the upper posterior final, and now you locked the occlusion, and then I would do the upper anterior. Okay, so so
lower anterior, lower posterior, upper posterior.
Upper anterior and then upper posterior. So again, lower anterior,
okay,
lower posterior, upper anterior, upper posterior. Having said that, if you want to swap, if you want to do lower anterior then upper posterior, upper anterior and lower posterior, you can still do that. But it's a completely different ballgame.
One pragmatic question I have for you straight away is, when you fit your lower anterior crowns or veneers, and then you maybe have to do a bit of adjustment of your upper provisionals, are you then taking an impression or a scan to send to the lab so that when they actually make the definitives of the upper, they're going to now copy your slightly adjusted temporaries?
No, because to be honest, you can do that. For me, I'm going to take them out, mount them, and redo them anyway. So the lab is only using the shape of the incisal edge, incisal length, and the bulk of the buccal as a copy, which I'm not going to change most of the time. It's just the palatal, which is occlusion. So I don't really bother taking another impression, because we're going to remount the models anyway. So patients, I'll get the occlusion right. So no, I don't, but you can do that.
At what point have you had to redo the facebo as well?
Every single step, yeah. So every single time I'm doing indirect, I would do facebo, new impressions and everything. So it becomes a lot of big stretch. Huh? So that's what I'm saying. Indirect is completely different ballgame than doing a direct composite or doing any composite, right? Because you can adjust things a little bit in the mouth. You can polish really well, and it's a bit more forgiving than doing a indirect restoration porcelain.
You're spot on. With composite, you really do get to use the patient's mouth as the articulator, as we discussed so much in episode 1 and 2 of this series. Whereas with indirect, you're relying, you don't want to do as much adjustment of your ceramic, your glazed ceramic. So therefore, you don't get the opportunity to use the mouth as an articulator as much as you can do with composite, which is why when you're starting out with rehabs, just like the reason why we're recording today, Dev, is when you're starting out with rehabs, adhesive is a great way to learn.
100%. And I would recommend starting with adhesive full mouth reconstruction, because it will take away a little bit the fear of what if something goes wrong, because it is more forgiving. It's not completely forgiving, which means you can't go back to zero, but it's much more forgiving. So I would personally start with adhesive reconstruction. Having said that, any full mouth reconstruction, you need to be really good at doing single tooth dentistry, and that's why when I started posting more and more on social media, and if you're not following me, then please follow me and you'll have some more information. But
please do, some great content.
And I started with posting single tooth dentistry. I started posting single edge bonding, and people like, oh, but you do full mouth reconstruction, why are you posting? I said, look, you know what? I want people to understand that they need to be really good at doing single tooth dentistry in order to do the full mouth reconstruction. You can't have a rubbish, because you will have, if you do rubbish 1 tooth, you're going to do rubbish 28 teeth when you do full mouth reconstruction. So you need to be comfortable doing a single tooth dentistry, And again, when I teach single tooth dentistry as well as full mouth reconstruction. So when I do courses of full mouth reconstruction, I would teach good single tooth dentistry because I know that that's the foundation to do full mouth reconstruction. Okay, so once we've done all that, make sure that now we're at the stage where we're building upper and lower 3 to 3. Okay, so that's composite build-up now.
So
from
we're
now
making a
on,
transition now back to direct. We're making a transition back to adhesive now, guys.
Yes.
So, Dev very kindly spoke about the indirect protocol to give you a bit more value from all this series. So look at that, adhesive, but he's also giving you some structure for indirect. But let's go back now. Put your frame of mind back to adhesive.
Yeah, so now all the steps are adhesive, which is composite, direct or indirect build-up steps. Okay, so now we're building front teeth, upper and lower, with direct composite, right? So, composite. So when we're building upper and lower 3 to 3, you have 2 options. Well, 3 options. You can do direct build-up using composite. You can do indirect build-up, or you can do semi-direct build-up. Okay, so if you're doing direct build-up, you can use freehand technique, which I wouldn't recommend. You can use putty indices from your wax up and use that to create incisal edges of the lowers. So I always start with the lower first, even if it's the same appointment, I'm doing both. I'll start the lower incisors first. So I'll use putty indices for lower if I want to. You can use something called Memosil, which is bluish material which you can cure through. But I prefer Exacclear, which is a GC product, which is amazing. And so once I started using that, I don't go back. That's the product I use for making my indices. Mm-hmm. So Exacclear I use for making the indices for the incisal buildups. Or if I'm going to do palatal buildup, then I can use, and if it's not too thick, then I can use a single sort of buildup. So put the composite edge prime bond the palatal aspect, and I use OptiBond FL for all my bonding because I feel that gives me the best result. And composite onto the stent. I put some composite onto the tooth as well because if I'm going to have an air gap, I want that between the material rather than material and the tooth. So I would put composite on the tooth and on the indices, and then squeeze the indices to get the stent. If it's quite big, build up on the palatal shelves, then you can put a little bit composite, cure it, put a little bit composite, put a stent on it, take it out, make sure it's not really going anywhere else, cure it, and then you build in the increment using the stent by using like a stamp technique. So you just stamp it and make sure that.
But you're doing one tooth at a time here, because I can imagine doing multiple teeth.
I'm doing 3 teeth at a time, so I'm doing alternative teeth. Okay, so the way I would do that is I would I would put PTFE tape on alternative teeth, and I would etch bond cure the alternative teeth, and then start building up alternative teeth. So three teeth at a time. Okay, lower teeth to start with, and then the upper teeth. With regards to indirect, again, we're not talking about indirect today, but you could use crown veneers, all sorts of gold backing for the indirect. Or if you're not really comfortable building palatal, because that's where people are a bit more uncomfortable building the palatal sort of a shelves using direct technique, you can ask technician to build composite indirect shelves, and you can just bond it like veneers. Okay, with the composite, heated composite. That's what I use for if I'm bonding them. Okay, the semi-direct approach would be composite on the palate and porcelain veneer on the buccal aspect. And if you listen to Francesca Velletti, who talks about that technique as a sandwich technique, which I think is a little bit confusing, because we also in UK we talked about sandwich technique being posterior when you're registering molar, you have GIC and then composite on top. We call it as a sandwich technique. So I would call it direct indirect technique. So that's how I would build the lower and upper 3 to 3. Now there were 2 questions you were asking. One was, can I do everything in one appointment? You don't need to. So if you're doing lower build up, to me it will take, if it's a good quantity of upper and lower, like a lot of build up, it would take me 4 4.5 hours to do that. I'm slow. So, and I'm doing all direct. I'm not using injection molding or smile fast technique. That's another 2 techniques you could potentially use. To be honest, I don't have much experience with them. And so I can't really recommend long-term result. And people who have got long-term data, they don't have 10 years data on them. So I'm not sure. But you could use them if you want to.
I could just do an input here and say that having used for some significant wear cases using a full mouth adhesive rehabilitation, I've used both injection molding and smile fast, and it's just pick your poison, right? These are just techniques, tools. It's all about the planning that you do beforehand. So I don't get too hung up on which way I'm doing it. But having done a few smile fast cases, that 4.5 hours, because I'm like you, I'm slow. For me, that 4.5 hour appointment can become a 3 hour appointment. So I do save a little time, but then you're paying a little bit more lab fee as well. So it kind of works out, It doesn't have to be system specific. You should experiment.
Yeah, you can't do incisal in enamel. You can't really use different shades and everything, as far as I believe. So if I'm not doing buccal veneer, I would want upper incisor to look a little bit better. So by doing a little bit different incisal coloring and stuff. Having said that, I've restored lots of cases with just 1 shade composite, and they look quite good because the composites improved massively nowadays. So, and I use Genial. I mean, I don't get any kickbacks from them, but they support me for my courses, obviously. But they're really good material. Genial is amazing, so I really love it. And if you're using single shade,
I'm a huge Genial fan. I just remembered a quote from James Baker that I want to share with you,
James
listeners.
Baker, yes.
Is composite is a bit like being married to a supermodel. Composite is a bit like being married to a supermodel. Sometimes you forget how good looking they can be.
100%. Well, James' composites are really good looking. I know that. So
he's fantastic.
He's an amazing guy. So with regards to build up, so these are the techniques you can use. If I can't do everything in one appointment, if patients like I can't sit for that long, and if I'm not sure, then I would book patient back to back. So if I'm seeing patient on Monday, I'll book patient on Tuesday so that I can do the upper reconstruction. That means I don't need to worry about too much provisionalizing stuff. So I would have pre-planned both appointments, but I want those 3 to 3 done pretty quickly, rather within 1 or 2 appointments within 2 days, basically.
Hi guys, it's just Jazz interfering again with a really important message. Like, have you ever done teeth whitening for someone and the patient messages you or calls up or comes to your clinic upset because now they have these white patches on their teeth? At least 2 of you have shown me on Instagram some messages from patients that really concern you as a dentist because you weren't expecting these white patches to appear on teeth. Now, this is I wouldn't say a common phenomenon, but when this happens, when you start teeth whitening, it can be scary for the patient and it can be worrying for the dentist. So I have my buddy Payman Langrudi to discuss all about this in this couple-minute message, which I think is going to give you so much value. If this has ever happened to you before, or if it's never happened to you, you probably haven't done enough teeth whitening and it's going to happen to you. So why don't we learn about the techniques to make sure that you are well prepared to A, warn the right patient that this could happen, and B, to reassure them, because it's something that's not permanent. I'm going to go into that in a moment. And I just want to take a moment and say thank you to Enlighten Smiles for sponsoring this podcast, this episode. As we know, Enlighten is the premium brand of whitening, and it's so great to have their support and to be aligned with them. So let's head on over to Payman Langrudi to talk about these white patches for a couple of minutes before we rejoin the main podcast.
There are something like 28 causes of white and brown spots. And so you can't tell by looking at it whether it's mainly a hypo or a hypercalcification that's caused that white spot. And those two things are very different. So when the peroxide comes across hypocalcification, it does cause chalkiness. When it comes up against hypercalcification, it doesn't cause chalkiness. It's harder to get through that area. So you can't, the basic point is you can't predict which white or brown spot will go chalky, but you need to tell the patient that there's a possibility that any of them might. So that starts off with actually noticing that there are white spots, paying attention to that, pointing them out to the patient. And then if the situation you brought up is actually very common, in that often if it's a hypocalcification, very quickly those areas go chalky. often whitening is the first thing you do in a treatment plan. And so you've got a patient who's not really been treated much by you already, and the first thing that happens is something like that. And the key to it is to inform them that that might happen, and then when it happens, you look like an expert. And it's often missed that people miss white spots, or maybe they see them but they don't tell the patient about them. So I think the key message is just inform your patient that any white or brown spot could go chalky. Now, what happens next? The vast majority clear up by themselves. Definitely within the rehydration period, which is a 2-3 week period. So 2-3 weeks after the end of even home whitening will dehydrate teeth a little bit. Most of them will then clear up. If they don't, for me, I think microabrasion first before resin infiltration. I've had much more success doing it that way around. For me, there are brown spots that bleaching will turn into white spots. Then microabrasion can reduce them. Then Icon can delete them. But the opposite way around doesn't really work. If you go Icon doesn't reduce something that microabrasion might delete. So for me, the right order is bleaching first, consent the patient. If you can see white or brown spot, consent them for microabrasion, resin infiltration, or even composite restorations. And then if you need to tell the patient, look, if you're after perfection, one or more of those may come into play. I can't tell you which one or any of them until we've done the bleaching first, because bleaching will often delete things by itself.
So once I've done that, I would check the occlusion. Because it's adhesive, polish everything nicely, make sure the occlusion's there, canine guidance and protrusive guidance using the incisors, canine guidance using canine, and make sure you have the space you wanted for posterior, right? Because sometimes you start grinding the teeth down, that means you're reducing the OVD. So initially you would have increased the OVD to have the nice posterior onlays done, and now you're grinding the teeth to get the context better, and you're decreasing the OVD. So just be careful when you're doing any adjustment that you're not going over the board. I would rather add something to it, so then you got a bit more OVD, than reduce it. Okay, so you can never have enough OVD, you can never have enough space, especially for technicians if they're making anything indirect. If you're doing direct, then yes, you've got a little bit leeway for posterior. Okay, so that's done. We're happy with that, polished everything, patient's happy. Now we need to make sure that we stabilize the posterior teeth. Okay, you can't, because patients now got the occlusion on 3 to 3. There's nothing, posteriors are in the air.
Patient now has a dull composite in their mouth.
Yes, exactly. So if you're going to do dull, perfect, you leave them as it is. If you're worried about them breaking things, then you can give a small S6 retainer for just the anterior teeth to wear at night time. I don't tend to. Patient tolerate really well. If your occlusion is really good, they don't tend to break it. And obviously your bonding needs to be
Agreed.
good. So they don't tend to break them because they're nice chunky composite. They're good strength in them. So I don't usually bother, even if I'm doing dull, I don't bother giving them any sort of appliance. I just let them go like that. If I'm not doing dull, then I would, which many times I don't. So I would use 2 techniques for the posterior stabilization, right? So you want to keep that space. That's the whole point. And give patient a little bit comfort, because if there's something touching at the back, patient feels a little bit better than just the front teeth touching. Okay, so the easiest way to do that is use your GIC glass ionomer cement, put it right in the center of the occlusal surfaces of the upper or lower. I select lower because it's easier for me to use. Put Vaseline on the upper teeth, ask patient to close. Okay, it's because your front teeth, your anterior teeth are nicely done. They will act as a stop, and the posterior teeth will close on your GIC, hopefully so touching the GIC, and that will then create, your GIC will act as a stop for the posterior. Okay, and nowadays GIC are really good. They last, they will stay in there. So I would put GIC there and close it. If you really want to be modern, you can spot etch, you can put a little bit bond, you can put some composite on there to get the stops, to get a bit more rigid stops. But GIC works really well, especially when you're going to remove them. You know where's the tooth, where the GIC, it's easy to distinguish rather than composite.
Having previously used composite for this, I now regret not using GIC. I think that's a really great idea, actually. So actually, I would now use GIC. But any consideration to GIC or its sexier superior cousin RMGIC?
No, I don't use RMGIC. I know people use it. The way I thought was that it's worst of both worlds, basically, RMGIC. So I tend to use normal Fuji 9 GC, obviously.
Sure.
It's really good product, and it works really well. I mean, I've treated patients, those patients who come to you with so many caries and you're just not sure where to start. You remove all the caries, put GICs in them. I was quite sad, so I used to carve my GIC using a small fine burrs and make sure nice. And they stayed like that for like 8 years, because some patients just go, right? So they don't have enough money or anything to then have the full mouth done, and they come back, and most of them are intact. So GIC is good material, although I still consider it as a provisional or a temporary restoration. It's a good material. They've come quite far. So I put GIC at the back. And
so what else you can use GIC? What else can you use?
So this the second thing I use. So I only do 2 techniques. GIC most of the time for adhesive composite ones. Most of the time GIC. The second way you could do that is if you have had done full mouth wax up, you can take indices of the wax up of the posterior teeth and put Bis-Acryl in there and put those posterior on there. So you need to do upper and lower, obviously, and shrink fit like we did on a mock-up stage. So you're going to do mock-up for the posterior teeth. For that, you need to make sure that you have the full waxed up model. Okay. So if you have a full wax model, that's
in this case, I'm thinking you'd be doing some bit of etch and spot etch and spot surface in areas.
Occlusal surfaces, I would do spot etch at the back because those provisional will stay there for some time because I want to make sure that I'm assessing the occlusion. The problem with them, in my experience, is that patient doesn't have freedom sometimes to move their jaw. And provisionals are not going to be, because it's shrink fitted and all that. It takes first of all a lot of time to adjust the occlusion if they're off the occlusion. And also you can cause sometime, because you haven't seated the putty properly or whatever, posteriorly, some sort of a non-working side contacts or some interferences, so then they're not completely relaxed. Whereas if I'm giving them occlusion just anteriorly, when I see them for review in 2 weeks' time, they're nicely relaxed because they're just nicely gliding on their front teeth. GIC is literally just flat, so there's not doing anything much. So again, if any of the tooth is poking into the GIC, I would make sure that I would cut the GIC so the only tip of the tooth is touching. I don't want posterior teeth to interlock into the GIC. I want them to be nice so that patient can glide on top of the GIC.
They're just occlusal stops.
Exactly.
Just preventing teeth from overrupting.
It's like you're doing Michigan splint. You want just to point contacts. You don't want like a indents into the splint. Exactly the same concept.
Great comparison.
And that's why if someone wants to do full mouth reconstruction, learn to do the Michigan splint. If you learn to do Michigan splint, you will learn so many principles. You will be quite comfortable adjusting things because when you do restoration, if you need to adjust, you need comfortable adjusting things. So if you want to, and that's why when I start teaching full mouth reconstruction, I teach Michigan splint first, and not because I'm that's the best splint or anything, but it just gives you occlusal concept. The dentist learn the occlusal concept, which you then going to transfer into your full mouth reconstruction. So my first 2 days hands-on is splint course. And they're like, oh, we are here to learn full mouth reconstruction. I said, by the time we finish, you will know why we started from here.
On acrylic.
not the last step. Last step is to give Michigan splint, but we start the first because they need to know that.
Fantastic.
Does that make sense?
Brilliant. Absolutely.
Perfect. So then we finished with the appointment number 5.
You've got the posterior stabilized now, so either you've gone the GIC way or the Bis-Acryl way. You've got the anteriors beautifully built up because they have upper and lower. You've got the posterior stabilized at that second visit.
Yeah.
How long are you waiting for before you now convert the posteriors to your composites, either direct or indirect? 4
weeks usually, because that takes the occlusion patient to get used to with everything, making sure patient's happy with it. TMJ is fine with it, patients relax. So around 4 to 6 weeks. I have done within 2 weeks, because patients something's coming up, we need to build it quickly. But my preferred way to wait for 4 weeks, because it's important that we assess before we go with the posterior. Okay, so 4 weeks is the time, and then after.
So now we're on appointment 6, is that right?
Yes,
so we
appointment
built the upper
6,
lower
yeah.
3-3,
So
and we're on appointment 6 now.
Appointment
Fantastic.
6 is before 4. So the next build-up is before, but I will see patient in 2 weeks' time or a week time, depending on how quickly I need to do the polishing if I haven't finished everything. So I'll see patient in 2 weeks' time to review it, to make sure occlusion's fine, patient's not, the CR's not changed, patient's bite's not changed since I've done the reconstruction, and then see them again in 2 weeks' time. So I'll see them 2 times in that 4 weeks for reviews. Okay, within that 2 times, the second time, if everything's fine, I would take impressions and I would mount models, because now inevitably things change a little bit. Okay, so from your first wax up, then I would mount the model and I'll ask technician. This time mounting model is easy because everything's ICP kind of, because everything's touching. You don't need to reduce as you go anything. Facebook, upper lower impressions, done. If you think the posterior GIC is not holding very well, then you can put small bite registration, but usually you can locate model really well, hand articulate. So Facebook, and do a upper lower impression, ask technician to mount the model, and then I would ask technician to do alternative teeth wax up. Okay, so I'm building, let's say I'm building 4, 5, 6, 7, I would ask technician to build 4 and 6, duplicate the model, and then build on the same model, build 5 and 7. So the second model will have all the teeth built up, but the first model will have only 2 teeth built up alternatively. Does that make sense? Because this will help in the appointment number 7 a lot. Okay, so this is this will save you time. I know and you can include the cost of second wax up again in patient's mouth. If you're doing digital, it's even easier to do that. You just need to click the buttons and print the models. But yeah, so I'll do second wax up, which is very important for me. It makes my appointment number 7 much quicker. Okay, so now technician got you got 2 sets of model. One model has got alternative teeth. The second model has got all the teeth waxed up. Okay, so you've got 2 models.
Are you doing just one quadrant now, or are you doing a full arch now?
So technician will wax up full arch, upper and lower, everything, because you can build them up one by one later on. But because your occlusion is locked or almost set now, technician can now go on and do alternative teeth for upper, lower, right and left, and then all the teeth for upper, lower, right and left posteriorly.
So you've got 4 models in total?
No, still 2 models. So first model.
Well, but what, 2 for the upper and 2 for the lower, right? Every other tooth model for the upper and a full model for the upper. And every other tooth model for the
so
lower
not per
and a full
jaw,
model for the lower.
but total 4 models.
Yes.
2 for the lower, 2 for the upper. So 4 models. Now appointment number 7. In 7, again, there are different ways you can build the posterior teeth. You can do direct, you can do indirect. But we're talking about the direct right now. So indirect, in the direct technique, my preferred method is using a stamp technique. So when I'm doing the GIC stops, I've intentionally not put GIC in between the teeth. So my GIC stops are going to be right in the middle of the occlusal surface. That means when technician has waxed up alternative teeth, my indices will sit really nicely using this in-between space of GIC really well. So I'm going to make again Exaclear index, and one of the struggle I had with Exaclear is very runny material. When you put a lot of Exaclear, it just runs through the model. So what I tend to do is I would put a little bit Exaclear just to cover the occlusal surface, wait for that to set, and then I'll put more, because when you put just to cover the occlusal surface, it will roll over up to...
It'll just droop.
Yeah, just drool a little bit. But if you don't put too much, if you put a little bit, it will only drool for up to a couple of millimeter on either side. Once that's done, I would put more. So I would build in layers. Okay, so but I need my Exaclear really thick. Okay, indices needs to be thick. If you can bend them, then they're no good. because when you push them, they will just flex, and the composite will go everywhere. You'll get flat-ish crown, or it won't the flattish composite, and it won't be as accurate as you're mounting. Okay, so then I would build again etch, prime bond, PTFE on the teeth which I'm not building, and I would in posterior teeth I would do one tooth at a time. So in the sense that although I'm doing alternative teeth, if I'm building 4 and 6, I'll build 6 first and then build 4 separately. I'll do one tooth at a time. I don't want to do 2 teeth on posterior. One tip when you're doing that.
Doing this, are you using rubber dam isolation, or does the fact because of the Memosil it makes it difficult to do that?
Yeah, people say that
because
actually.
the clamps in the way. How do you find it?
I have photos actually. I can show you at some point. But I do use rubber dam. I know.
Good.
Personally, I know that there is no evidence, at least even in my dentistry, where I've used rubber dam, where I haven't. They both worked superbly well. But it just reduces my stress. When I'm putting rubber dam on, I can go for 100%. A tea break, come back, and I know that everything's going to be the same. The
patient go to a toilet break.
Yeah.
How many times a patient with a rubber dam on just gone for a toilet break and come back?
Everything's same. Everything's same. So I prefer. That's the reason I prefer rubber dam, not for scientific reason that it's going to. Obviously, it will hopefully help with bonding and everything, but there is no kind of scientific evidence per se to suggest that rubber dam helps with that. So I prefer rubber dam for sake of, and that's why you can't use rubber dam if you're doing smile fast, because you need your or injection molding. You can't use rubber dam, and if patients got a lot of saliva and everything, it's very difficult to do that.
The best you could do is a split dam in those ways, but usually it just gets in the way. So usually in the anterior, an obturate will be fine when you're using those other techniques.
Yeah, obturate is obviously just a cheek retractor, isn't it? So it just helps you move the cheeks away. Mm-hmm. So I would do number 4, number 6. Once I build them up, I would then number 5 and 7. So that's whole arch is done. Number 5 and 7. So you will have 2 indices per arch. Per side you're building, yes. Right? So the one indices for those alternative teeth using that model, and the other indices for again the other teeth using the final model.
Yes.
The one tip when you're using the stem technique is that you make sure that your indices are not extending too much beyond your wax up buccally or lingually. That means that if the wax up stops like 1/3 of the buccal, you just stop 1 millimeter after the wax up, beyond the wax up, your indices, so that it's easy to clean the excess away, and excess comes out easily as well.
Really great trick.
Okay, so just make sure that it's not going right to the gingival circles, but otherwise you'll have a nightmare.
And then also it gives you space to put the rubber dam, because if it goes all the way to the gingiva, your extracurricular index, then the rubber dam will push it up. So you need to just go slightly beyond the wax up, just as you said.
Yes, and obviously check the indices fits after you put the rubber dam as well, because otherwise you load everything and then the indices is not fitting. So making sure.
Here's a really good idea I just want to share. You probably do this already, but one thing that Harmeet Grewal taught me is that when you're making your exoclear on the model, your every other tooth or the full arch, you put the rubber dam clamp you think you'll be using on the model. So now the rubber dam clamp is there as you're doing the exoclear, so that it's less likely to interfere, right?
Yeah.
And obviously it's not going to be 100% accurate, because the way that it will clamp in the mouth might be different because soft tissues, but it just gives you another little trick up your sleeve. So turban tip to Harmeet Grewal there.
That's very good. It's a good tip actually. I never thought of that. I would just cut it and then use it. But yeah, it's a good tip. Thank you. I'll try that next time. So I'll build them up, and then I personally prefer to do one arch. So I would prefer, as I said, to do lower arch first if I can, build up, and then move on to the upper arch later on, because then if I'm doing lower arch, then I'm getting occlusal plane correct, making sure that everything's fine, because for me, if the lower occlusal plane is right, then the upper will fall into place. So I prefer to do lower arch first, but I've done up one side at a time as well, because it's just easy as well for patient, because they got one side bite and then the other side is GICs. Does that make sense? So it doesn't really matter too much as far as you're comfortable that your wax is accurate and you're going to replicate that in patient's mouth. So I've done direct build-up.
Just to clarify, you're doing the right side at one appointment and the left side at another appointment.
Yes, but you can do lower arch in one appointment and upper arch in another appointment. Does that make sense? But
Sure.
but for patient, it's easier if you do one side at a time because they got nice bite on both sides.
Yeah, I like the idea of that.
So I think that's where we finish with the reconstruction. Take everything off, make sure everything's nice and tidy. Patient's happy with it. Obviously, you can do direct build up directly, right? So you can do build up directly if you're really comfortable. And I've done that. Lots of cases doing that. But it's just STEM technique makes my life easy, and I just don't like difficult
100%.
life. So I like to make my life easy as much as I possibly can. Because someone was telling me about extractions, like I can extract a tooth using, one forceps. I said, why make, if something makes my life easy, I'll use that. I don't want to show the skills. I want to be the dumbest dentist using the best tools and get the same result. What's the point? So do whatever, as long as the end result is good, then that's fine. So once you...
So now what you essentially have over the few appointments is you've got your complete rehabilitation done now, because over 2 appointments, you've done maybe the left side one appointment, the right side the other appointment, you've done your polishing. I find these interproximal saws really useful at these appointments to anywhere where the bond or the composite is joined together to clean away. Interproximal polishing. I love using Eve Twist polishers personally, my preferred one. What kind of polishers are you using?
I use... I've used A-Twist, which they are really good. So I've got different types of it. So the Kerr does nice polishing burrs as well, composite polishing burrs. They wear off quite quickly, but they give really good polishing results. But I tend to use Astra brushes. The Astra, the golden ones. Those polishing brush.
Astra brush. I think I know what you mean. Yeah, they got a gold tint to them.
Yes, and those are the one. They're alumina impregnated bristles, I think. They are good with the white stone and the red. So the gross sort of cleaning is done by using red striper burr, then the white stone, and then the polishing using Astra or some sort of a cup or something like that. So that's all done, and patients now you assessed the occlusion, make sure everything's fine. Now I review that for a couple of appointments because things can change over the time. Review for a couple of appointments, and then maintenance phase would be to fit some sort of a protective appliance, which is, for me, it's Michigan splint to start with. However, if I don't see if it's a patient with erosive wear, there is no need to give them Michigan splint. I would give them a soft mouth guard.
Low functional risk.
Yeah, exactly. I would still give them some sort of a mouth guard to make me feel happy. But they don't tend to wear anything, and they're still fine. So I mean, if you want to really assess the risks, which would be your first case, a trission case or erosive case, I would select erosive patient all night long. You can get really predictable results, very less complications than attrition patients. There are things you need to be a bit more accurate. But again, technique-wise, adhesive versus indirect, sort of a composite versus indirect porcelain, start with composite, then move on to porcelain once you gain some experience and got some cases under your belt.
Amazing, Dev. You have fully blown us away with all these appointments. I'm just going to ask you a few more micro steps. Then when I hear about how we can learn more about full mouth rehabs from you, because you said you got some courses and we're learning live stuff, online stuff. Before we come on to that, though, I just want to find out how long you tell your patients that this adhesive rehabilitation will last, and what is in the contract in terms of, like, for example, when I do bigger cases, I make it clear at the beginning that if you don't attend for at least one annual checkup and some hygiene, then anything chips avoid, you're paying for it. But in the first year, anything, because I'm confident in my sort of diagnosis stuff, any issues, I will be there for you. But you also need to do your part. So what are you telling the patient? Obviously, you were told him beforehand, but it's a good point now that you've described the process so beautifully, and you're at the end now, to describe the terms and conditions of this marriage.
Again, so basically, with regards to patient, I would have had this conversation, obviously, as you said, beforehand, before I've done all this. So I always tell patient that the composite, and again, I'm glad that you brought up this point, because when I started my career, I did lots of composite veneers, right? So that's how you start, because they're easy, cheaper. Patients say yes to composite quicker because they're almost half the price than the porcelain veneers. You can less appointments, more control, because I can control the anatomy, I can control the shade. Whereas if you send it to lab, depending on how good the lab is. So I did lots of composite veneers. But if you ask anyone who has seen their cases 10 years on, which I have, the mentality changes a little bit. I do not select composite resin because they are cheaper modality. I tell patients that, look, in a long run, they will cost you the same as porcelain because they need maintenance, things will chip, they need polishing, depending on your diet, things will stain. Because I do everything same for all my patients, and sometimes some patient comes with staining every 6 months. I have got patient. And some patients come after 4 years and there is no staining, everything's fine, it looks really amazing. And it's not me, it's patients. So I've taken photos and I would show them to my patients before I start the treatment. Say, look, this is one patient, this is another patient. I'm the one done the treatment for both of them within few months like that. So it's not that my skills changed. And they're both showing different results because it depends on your diet, your hygiene, what you do. So I'm always telling them to take responsibility of what happens in their mouth rather than blaming towards yourself, okay? So that's very, very important to ask them to take responsibility. I tell them, I've tested different guarantees, and in my experience, it has made no difference to my uptake, okay? So what I tell patient is that I would guarantee for a year. If any chips or breaks or anything, I'll fix them. And then after that, you need to maintain it. If something happens, you need to pay for it. I don't expect this to be with composite. They look the best on day one when you do it, and then it's downhill. Now, depending on how good composite you've done, the curve of that downhill curve could be quite flatter and then, gradually going down. If you've done a really bad job, then after a month, it just starts going really steep downhill. So I would tell patients that 5 years is the time you need to expect from these things. And you may need some touch-up, some refurbishment afterwards. Whereas veneers, I would tell them around 8 to 10 years. The difference is that, again, 10 years experience has shown me that if I have a space and if I'm not damaging the tooth too much by doing veneers, porcelain veneer, I always prefer porcelain because it's less maintenance, from patient and everything. It's just much easier, much clean. So for me, it's not really cheap how cheap it is. The composite is how much damage I'm going to do to the tooth in order to, because if I'm adding a lot of wax, then porcelain veneer, all you need to do is just make a margin and you can stick a veneer in there. It's not a big deal. So with regards to composite build-ups for posteriors, for posterior onlays, I use something called bell glass onlay, which is a very old technique, which is a second generation composite from Kerr. And Pascal Manier used to use it before. Now he's moved on to composite blocks, and which I'm also moving on to composite blocks. But most of my 10-year-old cases are using those onlays, and they work perfectly fine. They really, wear properties are so good that they look really good. So for me, so that's what I tell patients. So they need to maintain their hygiene, 6 monthly hygienist, yes, checkups, 6 monthly checkup, and I give them 1 year guarantee. Does that help?
Thank you so much for that, and that helps a lot. And then just to say the problems I've seen from colleagues and from myself when I've made a mistake is when, in my planning of composite, I did not respect the material thickness that it needs. So I find when I've had posterior chipping, or my colleagues have had posterior chipping, is because in that area, over a cuspal tip, there was only 0.5 millimeters composite in that area. So I think the thicker the composite, the better it can handle the stresses. We know that composite is very good in compressive, and to minimize the tensile load by building in and dialing in your canine guidance and make sure it's nice and smooth, that will obviously improve improve the longevity. So respecting the material thickness and also the ideal occlusal scheme is why you're getting so much success as well, Dev, in that. So it's worth mentioning that. Please tell us, Dev, where can we learn more from you?
So I have, if you can go to my website, which is drdevangpatel.com, I have various courses there. I have a full mouth reconstruction online course. So I have a pathway to full mouth reconstruction, okay? Because I want all general dental practitioners to be able to offer a full mouth reconstruction treatment to their patients, at least the adhesive full mouth reconstruction. For that, obviously, they need to make sure that their single tooth dentistry is good, which I include that as well in my course. So the level are that there is an online course which describes everything what I've discussed today, plus a lot more. It's around 20 hours worth of online lecturing and on practical demonstration of all the procedures. So there's practical demonstration of all the procedures. And it covers everything from start to finish. Then and my aim is to make sure that when someone does online course, they start doing some sort of if a single arch dentistry is something, just by doing online course. So that's how I made my online course. However, we are hungry people. So, if someone wants to really get into nitty gritty and do a hands-on course, then the level 2 is the hands-on course. So that's what I do as well. And once the hands-on course is done, you will have, dentists will have a lot of confidence in doing treatment. And if there are dentists who are like me, who they need someone sitting next to them for that very first case, then I'm doing one-to-one mentoring as well. So I will go to their practice and make sure that when they're doing their full mouth reconstruction, anterior and posterior reconstruction, I'm there sitting, nursing for them, so that they get the confidence there. Because once you do the first case, then everything else becomes easy, because you've gone through that process and you feel a bit more comfortable. So some people just need that, just a little bit extra nudge. But pathway is basically at the end of this pathway, either some people do online course and they'll be able to do full mouth reconstruction. Some people might need hands-on and some might need one-to-one. But at the end of the pathway, everyone should be able to do full mouth reconstruction adhesive using composite. So that's the aim. And that's the message I want to spread to all the GDPs, because by doing that, we're actually serving our community better. We're making sure our patients are better treated. Because I see a lot of colleagues missing, because if you're not doing the treatment, like you will see in practices where one dentist is doing Invisalign cases like 10, 20, the other dentist is not doing any Invisalign cases. And you're thinking the patients are the same, and it's the same practice. It's because that person is doing Invisalign and is seeing more. So if you're doing full mouth reconstruction, you'll start seeing the patient, because before that you probably didn't look at it properly. It's like buying a car, right? So if you buy a car, you start seeing the same car a lot on the road. It's the same thing. But yes, so if you follow me on Instagram,
and I just want to say that is amazing.
Yeah, if you follow me on Instagram at Dr_Devang Patel, or Facebook Dr. Devang Patel, or go to my website, which is www.drdevangpatel.com, or reach out to me. And if you have any cases, I'm more than happy to help you guys.
Dev is one of these really helpful guys, always got time for you. So thanks so much for being so giving to our community. And I just wanted to say, when I saw you in Edinburgh at BACD, we were talking about this, and we were talking about how in the implant world, they have such good pathways and good protocols with ITI, and mentorship is such a huge part of learning implants, right? Whereas when we find that when it comes to this type of dentistry, unless you do a taught postgraduate master's degree, you don't really get that opportunity of someone coming to your practice and doing that, which is absurd, because when we're charging the amounts we're charging for full mouth rehab compared to 1 or 2 implants, they're fairly comparable. So to have that ability for level 3 in your case for those who need it, I think that's fantastic, and I think this is the future. I know the future is online as well, and I'm a huge fan of online education, but I think it's great to have that option of having over-the-shoulder learning, which I think, to this day, is the most powerful way to learn. My most powerful learning experiences have happened when I'm shadowing someone, or someone's shadowing me, and I see how much they're gaining. And I think that's what you're providing. So kudos to you, Dev. Thank you so much for giving your time over the 3 episodes. It's been most enjoyable speaking to you. And I'll put all the websites up. And anything that you send me in terms of photos, PDFs, whatever, I'm going to stick it all on the blog post. And then hopefully people can log onto your website, see all the different stuff you have, and to follow you on social media so they can check out all these cases and all the tips that you share. I really appreciate you coming on, Dev. Thank you so much.
Thank you for having me. Yes, thank you very much.
And there we have it, guys. Thank you for listening all the way to the end. Dev was spitting fire, as they say, right? It was absolutely phenomenal. It's kind of like one of those episodes where you could not do multitasking, right? You could not do multitasking. If you're chopping onions, you probably chop your fingers, right? So it's one of those episodes. Hope you enjoyed it. Hope you found value from it. You may have to listen to it again and maybe a third time, just to cement it, cement the ideas, the bigger picture thinking into your head. So I hope you enjoyed that. Please do join Full Mouth Reconstruction for GDPs. This is Devang's little group on Facebook, which is just some loving seeing posts from other dentists and Dev sharing his workflows. Lots of great content on there. So do join Full Mouth Reconstruction for GDPs. I'll put a link in the show notes. And of course, if you want to learn more from Devang Patel, there's so many courses that he does, got like little mini courses. So if you liked his style of education, you should definitely check out his courses, especially when it comes to full mouth rehab stuff. He's got courses on that, and I'm going to put his website. I'll put it down below for those watching on YouTube, and I'll read it out for those who are driving and then sort of making a mental bookmark for later. And of course, I'll put it in the show notes so you can click onto it easily. It's drdevangpatel.com/courses-hub. So essentially, if you go to his website, drdevangpatel.com, you'll find the courses section, and you can check out all of the amazing courses he's got on there. Dev, I know you're listening to this one. Thank you so much, my friend, for making this 3-part series. It's been absolutely epic. I'm sure everyone's going to agree. And what you've given to the Protrusive is amazing. So please, guys, show your support. Join this course. If you want to learn further, if you want to enhance your full mouth thinking, check out Dev's course. Thanks so much, Dev. And thank you for listening all the way to the end.